And the last speaker before lunch is Dr. Jin Chan. I think he's well known to all of us. He's not here. Can we call him? He's not here? Jin Chan is the General Secretary of ICMART. He was the president of ICMART from 2010 until 2012 and the president of the Australian Medical Acupuncture Society in the area of Queensland. And he's very much involved in training programs, organizing, standardizing acupuncture, and of course, helping ICMART in all the facts. Please, Dr. Jin Chan, dear boss. Waiting for Dr. Jin Chan, I would like to tell you about other congresses, international congresses on medical acupuncture before 2018. It's the ICMART Congress of this year, 2016, will be in Sofia, Bulgaria. And the first announcement of the Congress of 2017 will be a cooperation between PhilAsthma and ICMART, and the next Congress for 2017 will be in Mexico City, where two big associations will cooperate for this Congress. And for 2018 we don't know yet, so we will have news soon. Dr. Chin, please. Abu Dhabi, yes. So please join ICMART. You are very welcome to join ICMART and help us in all what we do. And it will be our pleasure to come here and organize a World Congress in your beautiful country, or wherever we go to the desert. Thank you very much.
Okay. The topic of this talk is the piriformis syndrome. Now, the learning objectives are to review the piriformis syndrome, talk about the anatomy of the piriformis muscle, look at trigger point locations, emphasize the importance of taking a good history, and then look at needling techniques and stretching techniques. Let me preface this by saying that the piriformis syndrome is part of back pain, buttock pain, and sciatica. This is only a small part of it. There are many other muscles that need to be addressed if you're treating back pain and sciatica. However, piriformis syndrome is very central, and I find it is a major cause of buttock pain. Now, the piriformis syndrome presents as buttock pain with or without pain radiating down the leg. At medical school and as postgraduate students, we are taught to think of that type of symptom as being due to nerve root entrapment. Classically, disc pathology, a ruptured disc trapping the nerve root, or with aging, facet joint arthropathy, narrowing the exit foramen, resulting in pressure on the nerve root. And given those scenarios, the only treatment really is surgery of some sort to remove the prolapsed disc or to drill out the calcification in the exit foramen, which is causing pressure. Now, these are the symptoms of piriformis syndrome. Pain, you may or may not get paresthesia, pins and needles. The pain can be in the lumbosacral spine, in the buttock, in the hip joint. People are uncomfortable sitting. When you talk to them in the room, they will squirm. They will sit with one buttock off the chair. And if you question them, you can elicit that information. Sometimes they get pain in the perineum. And rarely, but it does exist, sexual dysfunction can be interrupted. There's pain during intercourse, and in the men it can result in impotence depending on which nerve is being trapped. How does piriformis syndrome come about? A sudden strain or heavy exertion which results in stretching of a muscle, overstretching of a muscle, tearing of soft tissue, all of those can precipitate piriformis pain. If you have a significant event and you tear a muscle, then the cause of that event is immediately obvious. But patients will often come to you with the symptoms of this syndrome, but they do not remember a precipitating event. Now, the event can be so gentle that they've forgotten about it. It can happen when you have gentle, repetitive stress. For example, if you say to somebody, hold this pen like that, 1 or 2 minutes, no problems. You make them stand there for 3 hours and the arm will feel like it's going to drop off. Now that will then leave the person with pain in the shoulder, pain in the upper trapezius muscles. Now, when people adopt ergonomically unsatisfactory positions, whether they're driving a car, sitting at a desk, and they do that for hours, that will bring on piriformis muscle pain. So it's not always a heavy event that brings it on. And what I've listed there are some of the things that can bring it about. The first one, the pointer seems to disappear when it wants to. Yeah. The first one, if you're not used to lifting heavy loads and you do so, you can bring it on. Quite often people will say that something was slipping off the table and they just rush to catch it, and that sudden movement is enough to cause the muscle injury. Golf is a common precipitator. I see many men golf players who come in with this problem, and you have to stop them playing golf for a while they're healing. People who drive cars long distance, the leg becomes tired, the buttock becomes tired, and it will bring on piriformis pain. So what are the causes? It's the activation of trigger points. Now, quite apart from what I initially talked about, nerve root entrapment, these are some of the non-classical causes. Trigger point activation, trigger point in piriformis muscle. Of course, you can have nerve root entrapment, and occasionally, because of the interaction with the sciatic nerve, you can compromise the vascular component in the leg. Okay, let's have a look at the anatomy of what we're dealing with. Piriformis comes from a Latin word pirium, meaning pear-shaped, and you will see here that piriformis muscle is in fact triangular or pear-shaped. It arises from the surface of the sacrum, the middle of the lateral border of the sacrum, as I've highlighted there. Its insertion is here, over the greater trochanter. The nerve supply is S1 and S2. Its function is mainly on the hip joint. When the hip joint is extended, it is a lateral rotator. When the hip joint is in 90-degree flexion, it is an abductor. When you are palpating piriformis muscle, there are two layers. On top is the gluteus maximus. So in order to feel anything in piriformis, you have to palpate through gluteus maximus. And that can be confusing because gluteus maximus in itself develops its own set of unique trigger points. And the secret is knowing the pain radiation pattern of each of those trigger points, and you can differentiate. Now, the piriformis muscle sits just below the lower border of gluteus minimus, right there. The sciatic nerve runs anterior to piriformis muscle. there are some anatomical variations of the sciatic nerve. In this first one, in 85% of people, the sciatic nerve, the normal variation is it runs anterior to the piriformis muscle. Here, the sciatic nerve is divided into a tibial and a peroneal portion. One runs in front and the other runs behind the muscle. 10% of the people have that, not a big problem. Here, where the sciatic nerve is in two branches, the peroneal portion is running through the piriformis muscle, and that occurs in 2 to 3%. Now, if that portion there is running through the muscle, then when the muscle contracts, it's going to squeeze that nerve and you're going to get radiating pain. In 1% of people, the whole of the sciatic nerve runs through the piriformis muscle, and that's a problem because when you get some tension in the muscle, they're going to get sciatic pain. What are the clinical findings? The piriformis muscle is tender to palpation, and if you search along the muscle, you will be able to define exactly which points are the most tender. Usually they're at the junction of the thirds. The patient will also experience limitation of movement. They often come in with a limp. They have difficulty sitting on that particular buttock. It is said that you can diagnose piriformis syndrome if you do a rectal examination because the muscle is tender. I have to confess I've never done that. Okay, that's just a highlight. That's the piriformis muscle. The trigger points, you can see here in white, where the crosses are the trigger points in piriformis muscle, and here you have a pattern of radiation from those trigger points. The solid red area is the main area of pain. The stippled red dots is an area of less intense pain. Now, if you look at that pattern, it looks like a posterior sciatica, which can be due to a nerve entrapment. These are the things you have to think of when you are presented with that sort of picture, and as a doctor, it is entirely reasonable that you systematically exclude these. Ruptured disc, degenerative disc, spinal stenosis, facet joint arthropathy, sacroiliac joint pathology. Hip pathology is important because so often we've treated these people with with buttock pain, and the pain is actually coming from a degenerative hip. I have not struck a malignant tumour of any sort, but I'm told they do exist, and occasionally you can get a large lipoma at the sciatic foramen. I have not seen one. Okay, you can treat piriformis by teaching the patient to stretch. Often that is inadequate. Physiotherapy, I think Janet Travell has championed using the cold spray and stretch technique. It's a non-invasive technique. Acupuncture I like. It's invasive, but not too bad. And trigger point injection, the musculoskeletal physicians will inject cortisone and local anaesthetic. My answer to them, my question to them is you're using a long needle and you're injecting a substance. I use a long needle and I get a result as well. And the common factor is the needle. So is the substance necessary? If you treat piriformis syndrome successfully, often you will prevent unnecessary laminectomy. I have seen patients who have had back surgery and they come back recovered from the surgery and they have exactly the same symptoms. And their problem was not a disc pathology, but due to piriformis. And you treat those and the pain goes away. And I have been asked in the past, was the surgery necessary? And you have to tread very carefully. You answer it diplomatically. Of course it was unnecessary, but I don't tell the patient that. I have a friend who is a neurosurgeon, and I assist him at neurosurgery quite often. And I talked to him about this, and he said, piriformis syndrome is difficult to treat. He said, I had 3 patients, I cut the piriformis muscle and it didn't help at all. Of course it didn't help, it's going to make it worse. I have a friend who's an acupuncturist, he's a doctor, and he was one of my teachers. He's a bit older than me, and he taught me about piriformis syndrome. And he said, you treat it with rectal ultrasound. He has an ultrasound probe, he puts a glove on it, and he puts it into the rectum and he directs it at the piriformis muscle, and the patient will tell you that the muscle relaxes gently. I have never done it, I don't have the equipment. Now, treatment with acupuncture, I carefully palpate for the trigger points and I needle them with a long needle. The needle has to find the trigger point and actually go into it. Now, when you're talking about treatment of trigger points, there are a number of needling techniques, different techniques for needling trigger points. You may use electroacupuncture, but I would caution you not to do it first time because you are using a long needle and it's deep needling and you will invoke a serious reaction anyway. It's just needling a muscle. And if you add electroacupuncture to it, you push that patient over the edge and they will get a significant reaction afterwards. So no electroacupuncture on the first time. Now when you are treating, there are a number of things that you will learn. Firstly, needling the skin is almost painless. Under the skin is subcutaneous fat, and as you go through the subcutaneous fat, it's painless. It's like a hot knife going through butter. It goes straight in. When the needle gets deeper and it actually hits the piriformis muscle is in spasm. And what you will feel is that the needle is hitting something solid, like hitting a piece of wood. At that point, you warn the patient that it's going to hurt. I'm going to push the needle into the muscle. And as you push the needle in, the patient may feel a bit of twitching of the muscle. They will get an aching sensation. And not infrequently, you will reproduce the pain that they have been feeling running down the leg. And if you get that, the patient's going to get better. Of course, there will be failures. I have had failures. If that is the case, then you have to go back and explore all the other muscles in the buttock, gluteus maximus, medius, minimus, because they also cause radiating pain. There are 2 ways to treat the patient, in the prone or lateral position, and I will show you these. This is the prone position, lying on the tummy. The head's up this way and leg down there. That's the border of the sacrum there, and that's the greater trochanter there, and I've just penciled in, marked in the piriformis muscle. And you palpate that and you will find it will have tender points. That's a 60 millimetre needle, and I've marked the trigger point there, and that's the needle's in with low frequency electroacupuncture. And you don't run the electroacupuncture for too long, 5 minutes. In the lateral position, that's a diagram in the left lateral position with fingers identifying the trigger points in the middle third. This is what it looks like in real life. Yep. I've marked the border of the sacrum there, and I've marked the greater trochanter there, and through palpation I have defined the piriformis muscle and found the 2 trigger points. And these are usually at the junctions of the middle third and the outer and middle inner third. different view, 60 millimetre needle. And there they are, going in. That needle is in, that one is just under the skin. And there they are. Sometimes if your needle's long and the person's thin, you can actually hit bone, never cause the problem, you just retract it a bit. The results of treatment, this is pre-treatment. If a person is sitting there and you're examining them, they will have great difficulty crossing one knee over the other. That is a very good sign it's probably piriformis. This pre-treatment one, unable to get the knee over properly. Unfortunately, this was another day and she had her trousers on. You can see that this is now crossed over and you can see the knee which you couldn't see here. And that's a good sign it's happening. Sleep position. Often patients will tell you that they learn to sleep in the fetal position on one side with the knees and hips flexed, and they sleep with the pillow between the knees because it reduces the pain. And the reason for that is when they sleep on their side like this and the hang on.
2 more minutes.
Sorry.
Dr. Chin, 2 more minutes, please. 2 minutes.
2 minutes, nearly there. Sleeping in that position with a pillow between the knees prevents that top knee from falling over and stretching the muscle. This is how you stretch the patient. You teach the patient to do the stretching. That hand there holds the pelvis against the bed, and this hand pulls the knee away from where you're looking at it, and at the same time they're pushing back towards us with the knee, and that stretches the piriformis muscle. So the conclusions are it's rewarding to treat, especially if you have a patient who is unresponsive to treatment, especially after post-surgery. Do it before they have surgery, and most important of all, listen to the patient, listen to the history. They will tell you that it is. Thank you.
So I would like to invite Dr. Jed and Dr. Sonia to come here for questions. Dr. Sonia? Dr. Jed, please. And you? Yes. Final. Dr. Sonia is not here.
No. Oh, okay. Everyone.
Of course. Okay. Any questions? Please.
A question for Chin-Chan, please. About surgery in piriform muscles and the non-success of surgery. The only patient I had with that, it was after surgery.
Did the surgery cause the problem?
No.
Or?
No.
I don't quite understand what you said. You said the problem was after surgery.
So that sort of patients sometimes have surgery,
Yeah.
but sometimes it's fail, and we have them for acupuncture after.
Yeah.
It's difficult to have solution.
Difficult to treat?
I try to treat
Yeah.
with no success.
Okay. Look, no argument with that. Sometimes you will fail. 20 years ago when I started out doing that, it was difficult. But over 20 years I have learnt a lot more and my failures are less. So the failure is not in the technique, but the failure was in my lack of knowledge. And to do that, I've evolved it over 20 years and I'm still learning, so it's not simple. If you do the occasional one, you're going to get failures, but if you do a lot, you will have less failures.
Thank you for the presentation. Please, doctor, I would like to ask about Why we didn't use musculoskeletal ultrasound for this case by reformers to detect the accurate point and to detect accurate point for pain, accurate differential diagnosis for another causes. I think, in my opinion, all practitioners working in TCM or any other modalities, we have to learn musculoskeletal ultrasound and Doppler, because I see many indications related to this. We can get more benefits for detection of points and for diagnosis, differential diagnosis, prognosis, treatment.
So your question really is, why did I not use ultrasound for the diagnosis?
No, I ask about why we didn't use musculoskeletal ultrasound in this case by reformists to detect the point and differential diagnosis for these cases. You have 7 differential diagnoses for these cases.
Well, when you say musculoskeletal ultrasound, that is just the usual ultrasound for soft tissue diagnosis?
Yes. Yes.
Yeah. Okay. Look, I don't use many diagnostic. I don't use CT. I don't use MRI in cases like this. There is a place for it, but generally, when they get to me, they have already had lots of investigations and they have been negative. Sometimes they have had surgery. The diagnosis of piriformis syndrome is not possible, in my opinion, with ultrasound or CT scan. I have seen CT scans and seen MRI scans come to me and they say piriformis muscle syndrome has been excluded. And yet when you examine that patient, the signs are there. The patient responds to the palpation. And I think it's important to treat the patient and not the scan, not the ultrasound. And I just simply don't use them. Clinically, I can make the diagnosis.
But I think if you use musculoskeletal ultrasound, sonography, yes, it differs from another modalities for investigation like CT or MRI because it's alive inside the field. While you are doing investigation, while you are doing examination, you can do ultrasound, you can detect the point, you can differentiate from another, you can detect the point. Instead of determining by this is blind and this is under vision.
Yeah, I'm not familiar with the equipment you're talking about, the sonography. Conventional ultrasound, yes, but the special equipment you're talking about, I am not familiar with it. So it's blind, but if you have in your brain a map of all the known trigger points, it's not blind. Your finger will go to those points. You cannot do this treatment if you don't know where the trigger points are. It's like giving someone a textbook with all the drugs in it and a pen and a prescription paper and saying, here it is, give yourself treatment. You really have to have in your mind where the points are, then you can find them.
But it will make it easy, yes?
Sorry?
If you are a professional in this, it will make it easier to differentiate. Good, yeah.
Yeah. Look, I think we can discuss this all day, but I have no use for ultrasound because there's a response rate to treatment is so good. Yeah.
In my country, it's very popular to use ultrasound and mostly with athletic injuries, traumatic injuries, and then they do acupuncture or they inject a type of medicine. But if you are a good clinician, like Dr. Chin said, you can find the trigger point. Thank you.
Yes, sir, please.
Yes?
I want to ask one question about that studying. I saw you not try to make a comparison between acupuncture and the other methods. For example, drugs. What is the case indicated for surgical, contraindicated, and also for the ozone therapy is indicated for these cases. And also I ask you how many days, how many weeks, because if we do comparison, at that time can choose acupuncture or other method. the normal studying should be make a comparison between your method and the other methods in your studying place. Thank you.
It's for Dr. Chin, huh? Yeah.
I don't quite get the gist of that. You're comparing this to ozone therapy?
To other therapies.
Yes, ozone therapy, yes.
Look, I can't comment. I have no experience with ozone therapy, so I cannot comment on that. I really don't know.
So you can share some about this specialty also with your studying.
Yes, we know that it is an indication of ozone therapy, but this lecture was based only on acupuncture and trigger points. And if you want some info, how many times you asked, how many times usually you do the treatment of acupuncture?
How many treatments to resolve the problem? Anything from 1 to 5 treatments per week. So the treatment might be resolved on the first day, or it might be resolved in 4 weeks or 5 weeks, and the treatment is once per week.
And you asked also if we combine acupuncture with other treatments.
Yes.
Ozone therapy in Australia is not permitted. We had doctors who did it. They have been removed from the medical register, not allowed to practice medicine anymore. So even if I could, I would not.
Okay.
Another question? I think you're hungry. Okay, thank you very much, all the speakers and all of you. Sorry?
If I would like to refer a patient for acupuncture, what is the contraindication? When I should not refer a patient for acupuncture treatment?
Who's asking that?
So the question is that what is the contraindication for acupuncture treatment?
We cannot see you. Where are you? Sorry. Okay.
If I can answer that, there are no contraindications. Okay, acupuncture is a modality of treatment, it's a healing system, and it is up to the practitioner, the treating practitioner, to examine the patient, make the appropriate medical diagnosis, and decide whether acupuncture is appropriate. You make the referral, and it is the other doctor's duty to do so.
There are only a few, we could say, contraindication in very special conditions, like old people or when they have pacemaker for electroacupuncture or drug acupuncture. So you can say that it is a safe procedure, but of course there are a few things we should be very careful of. The bad treatment, we have sometimes hematoma or other side effects. We cannot say any procedure, we can say, okay, it is a safe one, but you cannot say 100%.
Sure. Thank you.
For the last session, we come back after 1 hour, yes? So now we can have the lunch break. Thank you.